Hello, I'm Dr. Michael Kessler, and I want to welcome you to the Master HeartQuest Professional Part 2, sequentially going through the HQP parameters. This should hopefully make it a lot easier for you to go through HQP. And here we go. So as we look at this, it's kind of a lot of information, right? And we're going to break this down into each panel for you so we can go through and basically help you navigate through the HQP. So first, before we start, we have to do the disclaimer. HQP is not intended to replace the services and or medical advice of a licensed healthcare practitioner, nor is it meant to encourage diagnoses or treatment of disease. It is for research and education only. Any application of suggestions set forth in the HQP or this training are solely at the discretion and risk of the health provider. Implementation or experimentation with any supplements, herbs, dietary changes, medication, and or lifestyle changes, including neurovisor, etc., are done so at your own risk and responsibility. It is important that you work within the scope of your professional license and state laws. Reproduction of these slides or the information on them on the internet or social media is prohibited without permission from me, Dr. Michael Kessler, DC. Thank you. So here it is. Here's step number 1. Yeah, you want to trust the data, but if you have rejections and you're in the cardiovascular section of the HeartQuest Professional and you see rejections that are over 20, do not go forward and interpret the HQP. There's probably some arrhythmias going on. And what I would suggest you do is make sure the patient wasn't moving. Run the test again, maybe in a couple days or whatever you want to do. Make sure they weren't drinking lots of coffee or doing stimulants or exercise even. And check it again. But if it remains over that 20 mark, then I would suggest sending them out for a consultation with a cardiologist. But you want to tell them in kind of a way that doesn't stress them out. And the way to do that is say, on your test, I saw some abnormal rhythms on the EKG, and it's probably nothing, but I would go check it out. And that's how I would present that. Okay. And why the rejections? Well, remember, when we look at the time domain and we're looking at the space between each R to R wave, that's a reflection of the sympathetic and parasympathetic nervous system, right? But when you have an arrhythmia, you're going to have a lot of variation, which without the arrhythmia, that would be a good thing. With the arrhythmia, it's going to make it look better than it really is. That's why you're not going to read it. You're going to look at the different parameters on the HeartQuest, one of them being rejections over 20. And you can look down at the scattergram and you'll see lots of scatter, and sometimes the menu will drop down giving you that warning. Step 2, we're going to talk about the 3 signals. Every HRV pattern reflects a combination of these physiological states. VLF, which is, the stress load, that's your HPA axis and its downstream hormones. And that is probably one of the big areas that we're going to see when people have a chronic issue over a long period of time. And so it's involved with the HPA axis reacting to the sympathetic nervous system signals in response to stress. HPA sends a signal, the hypothalamic pituitary axis, right? Sends a signal to the pituitary via what? Corticotrophin releasing hormone. And the pituitary signals ACTH, adrenal corticotropin releasing hormone, to the adrenal glands to produce cortisol. Okay, and this process uses considerable energy because it's putting out those hormones into the humoral system, and it takes a lot of energy to finally get to that adrenal glands to produce that cortisol. It's not as efficient as the LF and HF, which is the autonomic nervous system control system, which is fast speed internet. That's why sometimes the total power that you'll see is low, because the VLF is the dominant of the frequencies there, very low, that it takes, again, it's taking a lot of energy and using up, and you'll see, using up all the energy in the system, and that's why you'll see sometimes the total power being low. LF, stress response, that is both sympathetic and parasympathetic. But with low HF percent, it is predominantly more sympathetic. They're in fight or flight. But the big thing here is a big compensator on regulating blood pressure by the autonomic nervous system when there are issues with the baroreceptors in your carotid artery and your aorta that sense blood pressure. They're not able to read that correctly when we have stiff arteries. And who makes up for that? Your LF is trying to regulate, to make up, to compensate for that. HF recovery, again, that's your high frequency range, right? The green pie, dealing with parasympathetic activity, recovery, and stabilization. So every HRV pattern is a combination of these states. Pressure would be this, stress on the system and the response that's going to happen, usually the LF there, and recovery, again, the HF. So we have the three signals, and everybody is unique in how they deal with life and how the body is going to change, or where sometimes some people are going to be more VLF and some more LF and HF. But we need the VLF is the stress load on the body, the LF is the response, and the HF is the recovery. All patterns reflect an interaction between these states. So what you're going to look at is, what is the dominant state? Identify that. And that's the area that we're probably going to focus on, right? Step 4, can the system handle the ability to change, adapt? Well, if the total power is high, yeah, you can do it. But if it's low and it's depleted, not really. Total power equal the system's autonomic nervous system, central nervous system capacity to handle stress and recover. So if the total power is low, it's going to affect all those parameters that we just talked about. Step 5, stress versus recovery. LF is your stress response, HF is your recovery. Which side is winning, right? So sometimes we need to calm the system down, right, with the LF stress response. And sometimes we need to amplify the system and amplify that vagus nerve and bring up that HF for recovery. So again, pattern recognition: high VLF, chronic stress load; high LF, reacting, fight mode; low HF, poor recovery. See the pattern, and we're going to guide the direction. We're going to be talking about how to do that in possibly the next module or the one after that. Step 7, same number, different meaning. So you can have a high LF, but if you have a high total power, yeah, the system is still adapting. The system is handling that load. But if you have a high LF plus low power, low total power, strain, system is overwhelmed. So context changes everything. So again, when we're going step by step here, first check for rejections over 20, because then you're not going to look at the rest of the test. You got to rerun it, check it, and see if this is still showing rejections over 20, so you can send them out, and at the same time do the things that we do. Step 2, total power, low versus normal. We look at that next. Step 3, we look at the stress index, high versus normal. Step 4, the LF, stress plus blood pressure control. When you see that LF and it's a little bit elevated, or it's you have a high percentage, the big yellow pie there, Run the blood pressure, look at the pulse pressure, which is the difference between systolic and diastolic. We're going to do a whole module on that coming up, because that's really important to tell us if those arteries are becoming stiff. And that will put tremendous pressure on the heart. And we'll explain why. Okay? But we can help people if we know that. And it's very simple. Step 5, recovery and exhaustion. Recovery, it says recovery or exhaustion, because remember that, the HF, the green pie, we're talking about parasympathetic, we're talking about vagus nerve, we're talking about recovery here. But if the total power is low, we're exhausted. That's where that comes in. Step 7, another anchor markers. So you want to compare everything, because you never look at one thing. You want to compare everything to these particular markers here. So you want to see the pattern, identify the dominant signal. So anchoring example number 1. Here we have a high HF, like you see on the right, and low total power. If you looked at one of those, if you just look at the HF there, the green pie, oh, this person has really good recovery capacity, right? Without anchoring, in this case, without looking at that pattern, that's exhaustion. The numbers don't change, the meaning does. Here it is, anchoring example 2, balanced LF and HF ratio plus low total power. Looks normal. You got that nice balanced sympathetic to parasympathetic ratio, it looks like there, with anchoring, low energy system that cannot respond. There you go. Anchoring number 3, LF HF plus low SDNN. Okay. So you got a normal LF to HF ratio, they're at 1, because the range is 1 to 3. Without anchoring, looks fine. With anchoring, reduced adaptability, rigid system. Why? Because look at that SDNN, it's very low. So the anchor markers prevent misinterpretation. That's what I'm saying here. Here's another one. Well, it's actually the same one, but this one does show up a lot. And again, you guys should look at that. Right away with that great big green pie there, HF, high frequency percent parasympathetic activity. With a total power like that, this person's exhausted, right? Recovery signal present, but energy is insufficient. Okay. Here's another one. High VLF, and we're going to see that a lot, plus a high stress index. Look at that stress index. It's way over there to the right. Without anchoring, looks like an acute stress. You just see the stress index, but with anchoring, chronic stress load with active drive. In other words, you got that CNS HPA axis overactivation, probably pumping out a bunch of cortisol. Person's in a chronic stress state, So with anchoring, chronic stress load. So key point, VLF reflects underlying load amplified by active stress. So why this order matters? Well, number 1, again, data validity. Is the signal reliable? That's your, in the cardio screen, like we talked about, looking at those rejections over 20. Total power. Is there energy available for this person to be able to adapt and change? Step 3, stress index. What is the current state? Step 4A, LF. Stress response. And again, when we're looking at LF, I highly advise, if it's a high LF, big yellow pie there, check the blood pressure. And if it's a little bit high, it's probably compensating for the baroreceptor system that isn't really getting the signal properly to the part of the brain, the midbrain, the cardiorespiratory center that makes decisions and knows what the blood pressure should be, that sends that impulse down based on the blood pressure, if it wants to slow it down, through the parasympathetic to the heart, to slow that heart down, for example. All that information goes through the nucleus tractus saltaris in the brainstem. And when we get those baroreceptors that are sitting in the aorta or the carotid artery in stiff arteries, and it's not flexible anymore, it's stiff, that message is not going to get there. And so who compensates it? The autonomic nervous system that we're talking about and reading, specifically the LF. Now, and then we got the HF, recovery vagal tone, and we know how important that is. That's your green pie, right? And there's your red pie, chronic load, central nervous system influence. That's a much slower system when we're mostly in the red zone, and that's the majority of the pie, and it's going to use up a lot of energy in the system. Why LF matters? Low frequency matters? Well, low frequency reflects the stress response. LF supports blood pressure regulation, the baroreceptors. High LF plus low HF equals sympathetic dominance. LF rises to compensate and maintain stability in the nervous system. Or why HF matters. HF reflects parasympathetic vagal activity. HF supports recovery and stabilization. High HF plus low total power equal exhaustion. You're in an exhausted state. We have to build them up. And we're going to talk about how we handle all these different parameters. HF must be interpreted with total power. Why VLF matters. VLF reflects chronic stress load, represents the central nervous system, HPA axis influence. Higher VLF equal greater system burden on the nervous system. Probably also we're talking the central nervous system here. And I threw this in because, I mean, look at this person. They really don't have any HF there. There's no parasympathetic activity. And their total power, though, this was an interesting one. If you look at it, it's 2,131. The stress index is just a little bit over. So what is going on with this test? I'm not going to read this whole to you, but here's the total power. Total power is 2,131. It's adequate. Adequate energy is present, but being used for compensation, not recovery. So I thought that was a very unique case for you. You can read the rest, so you can go into the details on that. But clinical summary, the system is maintaining blood pressure through the LF compensation. It's trying to. Is driving, the red pie driving cortisol output via the HPA axis signal, not restoring through parasympathetic pathways. So that was just an unusual case, because with this, you usually have very low total power. So just to finish up here, if we see rejections over 20, right, we know that we're not going to read the test. We know that if you have low total power, high stress index, and a low SDNN, and a low RMSSD, the system is completely overwhelmed. So we got to stabilize first, reduce the stress load, and support recovery. And we're going to get into very specific details here. So you do not push the system in this case. You got to calm the system, support the recovery pathways, reduce overload signals. There you go. And we have step 11. And there it is. If you have, you got the data from the HRV metrics, the frequency patterns, the stress load, the recovery signals. You measure the system, and then you make decisions. Is this system overwhelmed? Is recovery impaired? Is stress dominating? Is variability reduced? Now you understand how to work with that person and that system. And then it helps you also with the treatment direction. Calm versus stimulate. Support versus challenge. Recover versus perform. You guide the system. So HQP makes the invisible visible. You are no longer guessing. You are seeing the direction of health. Better data, better decisions, and better outcomes. I want to thank you for listening today, and we will continue with the next episode. Thank you.